Alagaraj, you want to check your presentation?
Yes, sir. Just shall I share my screen,
Yeah,
sir?
you can share your screen. Sorry, 1 minute. I think I have to stop sharing.
Yes, sir. No.
Yes.
Sir, am I visible, sir?
Yeah, great.
Sir, I have a couple of videos, sir.
Just see if it plays.
Yes, sir. I will separate வச்சிருக்கிறேன்.
Yeah, சரி அழகராஜ்.
ஏன்னா இதுல சிங்க் ஆக மாட்டேங்குது சார் பிரசன்டேஷனோட.
ஓகே ஓகே. இது முடிச்சிட்டு ப்ளே பண்ண போறீங்களா எப்படி?
இல்ல சார், லாஸ்ட் ஸ்லைடுக்கு just before that I want to play.
Okay. Okay.
Approximately 2 clips வந்து 2 minutes sir, and one more clip just 10 seconds தான் sir.
Okay ma. Okay. Now you can stop sharing the screen.
Okay sir. Okay sir.
உங்க வீடியோ வரலப்பா.
சார் வீடியோ ப்ளே பண்ணவா சார்?
உங்க
ஃபேஸ் sorry sir, just a minute sir. Am I visible sir?
Yes, டார்க்கா இருக்கு. லைட்
இருங்க சார்.
ஃபேஸ் பண்ண முடியுமா?
ஓகே சார், நான் அதை சேஞ்ச் பண்ணிட்டேன் சார். just a minute.
உங்களுக்கு பின்னாடி லைட் இருக்கு, பேக் லைட்.
ஆமா சார். ஆமா சார், just a minute. Still it is dark. Okay sir. Sir, is it still dark?
It's better now. It's better.
Sorry about the light sir. Sorry.
No, இப்ப நல்லா இருக்கு, பிரைட்டா இருக்கு. Yeah, definitely. நல்லா இருக்கு இப்போ.
Shall I stop sharing the screen sir?
Yeah, please.
Okay.
Yeah, we got another 10 minutes more. உங்க இதுல you've got COVID admissions உங்க ஹாஸ்பிடல்ல? Sir, good evening, RK sir.
Good evening, GK. How are you?
நல்லா இருக்கேன் சார்.
Too early,
இன்னொரு 5 minutes இருக்கு சார்.
இல்ல. அப்புறம் ஆபீஸ் லைஃப்
போயிட்டு இருக்கு சார். கோவிடோட சேர்ந்து குடும்பம் நடத்திட்டு.
Very busy man, super busy man, thanks to COVID.
முடிஞ்ச உடனே சார், after today's session, ஒரு 5-minute synopsis of all that, because today is the last episode of this season.
Okay.
So ஒரு synopsis of all the episodes so far.
போடுறீங்க. சரி. நம்ம क्वेश्चंस எல்லாட்ட சீக்கிரம் முடிச்சிடலாம்.
ஆமா சார்.
சம் அப் பண்ணிட்டேனா.
அது only ஒரு 5 minutes சார். No issue.
No problem. இல்ல, take your time. இது 1 hourக்கு மேல போச்சுனா இப்படி ஜூம் பண்ணி எக்ஸ்டெண்ட் பண்ணிடுறீங்களா?
இல்ல சார், எனக்கு I have paid for it சார்.
அப்படியா?
ஆமா சார். Otherwise it is limited to இது
1 hour 40 minutes.
Maximum 1 hour வரைக்கும் எக்ஸ்டெண்ட் பண்ணலாம்.
Okay.
So I have purchased it sir. I have subscribed.
அப்படியா?
ஆமா சார். It comes to around $15 per month.
$15 per month. எவ்வளவு 1000 rupees?
$15 னா
1100.
10,000 sir.
15,000.
1,000 rupees sir.
அதான் $15 1,000 rupees.
ஆமா சார்.
Okay. நெக்ஸ்ட் கான்ட்ரிபியூட் பண்ண வச்சிருங்க.
என்ன சார்?
கான்ட்ரிபியூட்டரி கான்ஃபரன்ஸ். ஆமா, ஃபீஸ் ரெஜிஸ்ட்ரேஷன் ஃபீஸ். Alagaraja has come now.
Alagaraja has come sir. He's come online.
Sir, good evening sir.
Good evening. How are you?
Fine sir. How are you sir?
Yeah, fine. Put on little more weight.
Sir, kekla.
Already weighted man, put on little more weight.
No problem sir. No.
No problem. And
good evening, Krishnamurthy.
sir, good evening, sir.
Good evening, Krishnamurthy.
Sir, good evening. Hello.
எப்படி இருக்கீங்க?
நான் வந்து வீட்ல தான் இருக்கேன்.
ஓகே ஓகே.
எங்க இருக்கணும்?
இல்ல நல்லா இருக்கீங்களா?
நல்லா இருக்கோம்.
Good good.
Life is like that.
Nice to see you.
Which we never expected, in our life, that we will have such a long period of rest.
Probably.
How are you, VP?
All fine.
Still going to the hospital?
Yeah.
Okay.
Mari. All emergencies, semi-emergencies.
Okay. Okay, nice.
Okay, I'll mute myself.
Good evening sir.
Good evening, Alagaraja. Good evening.
Hello, Karthikeyan. Good evening.
Good evening, madam. What is your name?
Subzone flash orbital floor fractures.
Tomorrow.
అక్కడ ప్రాబ్లం రావట్లేదు అంతే కదా, అది వస్తుంది కదా.
Just a couple of minutes more, sir. Dr. Hariharan's just logging in.
As your video, sit and click on this. Start. Hello.
Access the camera.
Sir, good evening, sir. NCH.
Yeah, I think I'm there.
Yes, we can see you, sir. Sir, shall we start, sir? I think Dr. Raja has also come.
Good evening, sir.
Yeah, good evening. Good evening. Yeah, I'm seeing Professor R.K. sir as well. Okay, right.
Okay, sir. So we'll start off right now. Good evening, everyone. And another episode of STEP program, Star Teachers in Plastic Surgery, the Next Generation. Today is the episode 14, the final episode of this season 1. The first topic will be management of orbital floor fractures, and the speaker will be Dr. Alagar Raja. He's done his MCH from Kilpauk Medical College, Chennai, from 2008 to 2011. He has done further a fellowship for diabetic foot lymphedema and super microsurgery at Asan Medical Center, Seoul, South Korea, under Professor J.P. Hong. Dr. Alagar Raja is now professor at the Department of Plastic and Reconstructive Surgery and SIPRACS, Savita Institute of Plastic, Reconstructive, Aesthetic and Craniofacial Surgery, Savita Medical College and Hospital. His fields of interest are facial-maxillary, microvascular, and aesthetic surgery. And the person moderating this session today will be Professor N.P. Hariharan, professor at the Institute for Research and Rehabilitation of Hand and Department of Plastic Surgery, Government Stanley Hospital and Stanley Medical College, Chennai. Without further ado, we shall go over to the first session, management of orbital floor fractures, handing over to NCH sir, Hariharan sir.
I give the introduction, or you can start the
You can
topic.
You can start. Sir.
You mean I can give?
He can talk and then you can give your comments. Sir.
Yeah. I think you can start with the topic.
Yes.
Thank you, sir. Sir, visible, sir? Screen is visible?
Yeah, right. Yeah.
Good evening, everyone. First of all, I'd like to thank Professor GK for giving the opportunity. The topic is management of orbital floor fractures. Isolated orbital fractures accounts for 4 to 16% of all facial fractures. Along with the ZMC and NOE fractures, it accounts for 30 to 55% of all facial fractures. A ZMC fracture is the most common fracture occurring with the orbital fracture. Orbital fractures are due to interpersonal violence, road traffic accident, and sport injuries. Anatomy: orbit is a pyramidal bony wall containing eyeball with the base anteriorly and the apex posteriorly. The average adult volume is 30 cc. Growth of the orbit is completed 80% by 5 years, and it is completed between 7 years to puberty. Orbit is formed of 7 bones: maxilla, zygomatic, frontal, ethmoidal, palatine, lacrimal, and sphenoid. And it has got 4 walls: roof, floor, medial wall, and lateral wall. Roof and lateral wall are thick walls. Floor and medial wall are thin walls. This is a CT picture showing the bones contributing to the formation of the orbital cavity. So some key reference points relevant to the surgery. Frontal ethmoidal suture. It is 2/3 up the medial wall, corresponds to the level of cribriform fate. It forms the superior extent of the medial wall dissection. Anterior ethmoidal foramen. It's 20 to 25 millimeter from the rim, and anterior ethmoidal artery passes through the foramen. Posterior ethmoidal foramen is 12 millimeter from the anterior ethmoidal foramen, and the posterior ethmoidal artery passes through the foramen. Posterior ethmoidal foramen forms the posterior extent of safe dissection of the medial wall. An optic canal is 42 millimeter is from the rim, and the safe extent of dissection along the floor is 32 millimeter. And along the lateral wall, superior orbital fissure forms the safe limit of dissection. So coming to a Hammer's key area or posterior medial aspect of the floor, or it is also called as posterior medial bulge. This area forms the key support mechanism to maintain the vertical position and the anterior projection of the globe. So during reconstruction, reconstructing this area forms the key to restore the normal globe position. Coming to the types of fractures, isolated orbital floor fractures or pure fractures. It may be linear or trapdoor fractures, common in pediatric age group, or blowout fracture, blow-in fractures, complex fractures, floor fractures associated with rim and other fractures. Clinical examination, we have to check for periorbital ecchymosis, subconjunctival hemorrhage, paresthesia of the inferior orbital nerve, check visual acuity, check for ocular motility, and you have to check for diplopia. Check for the globe position and palpate the orbital rim for step, crepitus, or mobility. The patient complains of loss of vision, visual field loss, no light perception, then suspect optic nerve injury. Always take the help of an ophthalmologist for fundoscopic examination and to check the vision of the patient. This is a picture to show the globe position. In the hypoglobus, the globe is positioned inferiorly compared to the contralateral eye. In inophthalmus, the globe is positioned posteriorly compared to the contralateral eye. VBOF, white eye blowout fracture, coined by Jordan et al. In 1998, common in pediatric age group. There may be discrete evidence of fracture in the imaging studies, minimal to no soft tissue trauma. There may be no subconjunctival hemorrhage, hence it is called white eye blowout fracture. The patient usually presents with a restriction of ocular motility and along with the vomiting. So investigations, gold standard is CT scan, 3 mm cuts for floor and roof fractures, and 1 to 1.5 mm cuts for optic canal. MRI is occasionally taken to rule out optic nerve injury and associated brain injury. It's an X-ray, plain X-ray showing the orbital blowout fracture with the teardrop sign. CT scan coronal view showing the orbital blowout fracture of the floor with the herniation of content in the maxillary sinuses. Another blowout fracture showing the orbital M5 sigma. What are the biomechanics of the orbital fracture? There are two theories are there. Hydraulic theory by Smith and Converse, in which the blow is directed to the globe, which increases the intraorbital pressure, causing decompressing fractures into the adjacent sinuses. And buckling theory by Figino, where the blow is given to the strong outer rim, which causes the buckling effect of the orbital walls and it results in the fracture. Jacqueries classification of orbital floor defects. There are 5 categories. Category 1 is a low risk, and from category 3 it is a high risk fractures. So category 1, the fracture size is less than 2 centimeter. In category 2, the fracture size is more than 2 centimeter. The point is the bony ledge along the medial margin of the inferior orbital fissure is preserved, which is a key point for reconstruction. And in category 3, the defect is more than 2 centimeters, but the bony ledge along the inferior orbital fissure is missing, will be missing. And category 4, the entire orbital floor is involved with the missing bony ledge. And the category 5, the fracture extends into the roof. So what are the indications for surgery? Persistent diplopia, positive force reduction test, CT evidence of muscle entrapment, no clinical improvement for more than 2 weeks, in ophthalmos more than 3 mm, significant globe ptosis, orbital floor defect more than 50%. So when to intervene? There are two concepts are there. According to Smith and Converse, they suggested early intervention, that is before 2 weeks. And Potterman and co-workers, they have suggested delayed approach, which is wait and watch approach. More than we have to wait up to 2 weeks. So the Bernstein criteria for orbital surgery timing, it has got 3 categories. Immediate, which is less than 24 hours, mostly for fractures presenting with the significant diplopia and significant compromise in the globe position. And white-eyed blowout fracture comes under this category. And early approach is 1 to 14 days, in which there is no significant improvement after waiting for a considerable time in for conditions like diplopia or inferior orbital anesthesia. And delayed approach, where there is the diplopia and other conditions seems to improve, then we can wait and watch. So access to the orbit, 2 approaches are there: transcutaneous approach and transconjunctival approach. Transcutaneous, three approaches are there: subciliary or lower blepharoplasty, subtarsal or lower linear skin crease incision, or infraorbital. So what are the aims of surgery? To restore anatomy, restore volume, restore eye movements, restore aesthetics, and to prevent vision. Subciliary approach, it gives access to the orbital floor, rim, or infraorbital rim and lateral rim. The incision is usually placed just below the eyelashes. There are 3 approaches to subciliary incision. One is the skin-only flap, and another is the skin and muscle flap. Since these approaches are associated with high rate of ectropion, around 6 to 8%, the preferred technique is step dissection of converse, which accounts for less scarring and very good scar. So in subciliary dissection step approach, the pretarsal skin flap of 4 to 6 millimeter, leaving pretarsal muscle intact. This is the key point. We have to preserve the pretarsal muscle intact to prevent the lid drop in the postoperative period. And the orbicularis oculi muscle is approached in the preseptal plane. The skin and muscle flap raised and retracted, and dissection continued down to the orbital rim. Once the periosteum is incised, then dissection is continued in the subperiosteal plane to reach the floor. Subtarsal approach, lower eyelid skin crease approach, gives access to floor and orbital rim. The incision is placed below the inferior margin of lower tarsus, starts medially and courses in a lateral caudal direction. The sequence of dissection is skin, orbicularis oculi, infraorbital rim, periorbitum, and bone. Muscle is, in this incision, muscle is dissected from lateral to medial direction in the suborbicularis preseptal plane. Once the rim is visualized, periorbitum is incised and dissection is carried in the subperiosteal plane. Closure is done in layers, periosteum, muscle, and skin. The precaution to be taken during this dissection is to avoid the fat herniation into the operative field. Dissection must continue in the preseptal plane. And second thing is the periorbita incision should be placed below the arcus marginalis, which is confluence of the septum with the periorbitum. To protect the cornea, you can use a corneal shield or we can go for a temporary torsography. Another precaution to be taken while going for the lower eyelid approach is the application of frost sutures to the lower eyelid. It creates traction and lengthens the lower eyelid during the first phase of healing, and it prevents the vertical scar contraction. Transconjunctival approach, first done by Tessier and Converse in 1973. 3 approaches are there: inferior fornix approach for the floor, medial transcaruncular for medial wall, and with the lateral extension for the lateral rim and the wall. The inferior fornix approach, 2 routes are there: retroseptal routes, where the dissection is carried into the fat compartments of the lower eyelid; preseptal route, where the dissection is done below the lower tarsal border in this suborbicularis oculi preseptal plane. Retroseptal route, the incision is done in the depth of the fornix. Incision is done for about 8 millimeter, including the lower eyelid retractors. The conjunctiva and the lower eyelid retractors are undermined and extended from laterally to medially. The dissection is carried, once it is retracted, the dissection is carried to the edge of the rim, and then the periorbita is incised to access the floor. The preseptal route, which is the preferred route, the conjunctival incision is done below the lower tarsal border. Suborbicularis oculi preseptal space is entered. Blunt preseptal dissection is done to reach the infraorbital rim. The periorbital incision is done and subperiosteal dissection is done to reach the floor. The advantage of this approach is the bloodless field and lower incidence of ectropion and the entropion. Transconjunctival approach has got a little bit higher rate of complications, and particularly corneal injury, eyelid malpositions, ectropion and entropion, and in ophthalmos. Again, the precaution to be taken for cornea. Corneal shield can be used. If not, the posterior edge of the conjunctival flap can be sutured to the upper lid margin to give a protection to the cornea. So still the transconjunctival approach can be done. The advantage is the superior cosmesis. The only thing is it requires high precision and it has got a limited access. So coming to the reconstruction materials used for the orbital floor: titanium mesh, porous polyethylene sheet, bone graft, conical cartilage. Titanium mesh is readily available and it prevents the donor site dissection and time. I mean, we can avoid extra surgery time. Now we have got even preformed anatomical plate. So we can, our suggestion is to go for a titanium mesh. At certain instances, we have also gone for a conical cartilage, but we don't have experience with the porous polyethylene sheet or a bone graft. So post-op care, the patient should be kept in upright position to improve the periorbital edema and pain. Patient should be advised to avoid nose blowing to prevent orbital emphysema. Medications apart from antibiotics and analgesics, nasal decongestant, steroids and ophthalmic ointment can be given. We give steroid for 3 days. We give dexamethasone for 3 days. So all these drugs are only optional. So all post-op period should done with a complete ophthalmic examination, particularly to check the vision, extraocular motion. We have to check for diplopia. We have to check for globe position. If there is epiphora, then check for lacrimal duct injury. Post-operative imaging, it's our choice. You can go for a plain X-ray or we can go for a CT scan. Sutures are removed in the 5 days. So follow up, again, the same points. Check for globe position, check for diplopia, vision, lid problems, and check for scar. So the few operative pictures. The first picture shows the subtarsal incision, and this picture shows the exposure of the orbicularis oculi. And you can see the completed orbital floor dissection in both the pictures. This is the malleable copper retractor we use, which is a very useful instrument. And this is the pre-op picture of the patient, and this is the post-op picture. The advantage of subtarsal incision is the hardly we can identify the scar. So another case of subtarsal approach, completed orbital floor dissection. You can see the floor reconstruction of floor with the titanium mesh plate. Transconjunctival approach, again the preseptal root. Here you can see the conjunctival flap has been sutured to give the protection to the cornea. Orbital reminiscence approach, fracture is exposed for repair. I would like to play a couple of videos for the both approaches.
Alagar Raja, you have to stop sharing. Stop share, put it.
Sir?
You have to put it's playing.
Sir, is it?
Stop share. It's not sharing. You have to put stop share.
Sir. Sir, video is not visible, sir?
Yeah, it's not visible. You put stop share. You have to stop sharing the screen.
Okay, sir.
Then again put share. Yes, now again start share.
Okay, sir.
Then play on your video.
Okay, sir. Just a minute, sir. Shall I, sir?
Yeah, now you can click on the video.
Sir, shall I little bit fast forward? Sir, shall I?
Yes. So whatever important step you want to show, you can play.
Sir, one more video, sir. Sir, one more video for just 10 seconds, sir. Just I want to highlight that video. Sir, this is the real-time navigation guided orbital floor surgery, which we have started in collaboration with the Aravind Eye Hospital. And what you are seeing, this is the skull post that transmits the data to the monitor. And this is the tracer or the pointer which collects the data. And we have just only done 2 cases, 2 early, just we are in the learning phase. Probably in probably later we can come up with a good series of cases. And you can see the monitor from where the data is transmitted. Sir, PowerPoint is visible, sir?
Yeah, yes.
Sorry, sir. PowerPoint is visible, sir?
Yes.
Yeah, yes.
Yeah, sir, this is again the same thing, sir, the real-time navigation guided orbital floor surgery, which we have started. And this is the original setup in Aravind Eye Hospital, where we have performed the procedure. Just this is the latest thing we have done. Thank you, sir.
Yeah, you can stop sharing screen.
Yes, sir. Yes, sir.
Dr. NCL sir will take over.
I have few questions to
Yes, sir.
Professor Raja. First,
Yes,
I
sir.
thank you because this facial-maxillary, it's unfortunately not many plastic surgeons are showing attention. Not many are taking it seriously, partly because of lack of exposure. I can firmly say so much that when I go for exams, the first request that is often coming from the internal examiners is our people are not having adequate exposure to facial-maxillary. So often they are not exposed at all. So that is the problem we face. I mean, what is your preferred insertion and what is your suggested insertion for somebody who wants to take up
Yes. Yes, sir.
orbital floor fractures?
Yes, sir. Sir, our preferred incision is subtarsal, sir. It is the simplest approach we can go for. And so far, with our experience, we can firmly say that there is no complication like ectropion or entropion. Very safe, very straightforward, and very simple approach. And we have attempted, in fact, we have attempted subciliary approach. We had complications. Then we ventured into the subtarsal, and we are very comfortable. Nowadays, either we prefer only subtarsal. For selected cases only, we go for transconjunctival, particularly like isolated floor fractures. Only we prefer transconjunctival. Otherwise, we are very comfortable with the subtarsal, and we even we strongly recommend subtarsal approach, sir. It's very easy and very straightforward. It has got a very thin learning curve. I think all the surgeons, interested in taking up orbital surgery can go for subtarsal incisions.
Do you suggest to delineate a line, a subtarsal line?
No, sir. Actually, it is not. To be precise, it is. We check the lower eyelid skin crease, sir, which gets buried into the fold. We check for that skin crease that is below the tarsal level. That is what it has been shown in the video also. We check the preoperatively also. We check the incision, and we even educate the patient that this is where we have to go. We are going to put the incision, and we will show them the post-op pictures of patients, that is 3 to 4 months post-op, where they don't have any scars. So we convince the patient, then only we take up for surgeries. At the moment we say that we are going to put incision there, most of the patients, they object, particularly female patients. They say, but we convince them by showing the post-op pictures. Isolated floor fractures without rim, simple fractures, linear fractures, we strongly recommend transconjunctival approach, sir.
Yeah, the one suggestion, actually the lower tarsal plate is only 5 millimeter
Yes,
in
sir.
height. Just 5 millimeter.
Yes, sir.
So you avoid the subciliary, put an incision anywhere, and then retract the skin. It is very hard for you to injure the tarsal plate. Naturally, you will be in the subtarsal plate. You need not be very think that is, yeah, of course. You also preferred that. I preferred subtarsal or tarsal or subtarsal incision. Approach is subtarsal. There's no doubt about it. And scar is not visible. It's not. I won't even say barely visible. Scar is never visible. And second, in how much percentage of your cases you get entrapment of extraocular muscles? That is extraocular movement impairment.
Yes, sir.
Overall, you are seeing orbital fracture, either in association with zygomatic fracture or an isolated floor fracture.
Yes, sir.
How much percentage you get extraocular movement is impaired?
Sir, to be frank, I cannot commit percentage, sir. Let us take numbers like if we get 10 fractures, 2 to 3 cases we get entrapment of the soft tissue or muscles, sir.
Yeah, persistent impairment.
Yes, sir.
It's okay. We can say that means, on the other hand, 2 to 3, I even like to say 1 to 2. That is in 8. Surprisingly, in 80 to 90% of cases, we don't get extraocular movement impairment.
Yes,
you say even the worst of rim fractures or multiple comminuted thing fractures, this extraocular movement impairment is one of the very rare finding. In fact, we'll be looking for it to see and do this. Okay, I share the same thing. And how do you?
Yes, sir.
Yeah, how do you select the material for floor augmentation?
Sir,
do you have criteria or any?
Sir, selection, we always prefer titanium mesh only, sir. We assess the, perioperatively, we assess the size. Because we have got implants based on consignment basis. We have got 2 companies. So perioperatively, we assess the defect. If it is 2 centimeter or less than that, we'll go for that base plate type. If it is a little bit, if it's more than 2 centimeter, then we would like to go for a preformed anatomical plate, sir. We go like that. We go like that. We
How
have
much,
never. Yes, sir.
how much dissection you suggest along the floor? Is there any landmark I have to dissect up to here, or I have to go beyond that, like that?
Sir, as I said, 30 millimeter, we take it as a safe limit of dissection. But like we would not like to go beyond the inferior orbital fissures, sir. At times, we have ablated certain structures in the inferior orbital fissure. We have taken out the structures and we have gone beyond that. But for the beyond 30 millimeters, we usually hesitate to go beyond that, sir.
You mean to say you stop at the level of infraorbital fissure?
Yes, sir. Little bit, we go little bit, sir. We have even taken off the structures in the infraorbital fissure. We have gone little bit, but not beyond that, sir. We don't go beyond that.
So any problem in the infraorbital fissure you normally encounter, you have to dissect beyond that. So what is the thing in the infraorbital fissure?
Sir, mostly the dissection of the soft tissues only, sir. Dissection of the soft tissues that we face regularly. We not regularly, for certain cases we face that dissection, sir. Dissection of the structures, soft tissues along the infraorbital fissures. Sometimes the entrapment. We have to check whether we are just dissecting the muscle, or we are dissecting the structures in the infraorbital thing. That's what we face a little bit difficulty, sir. We face difficulty in that area.
I personally feel, because infraorbital, because structures are coming into the orbit through the infraorbital fissure.
Yes, sir.
If we have to go, we have to cut those structures.
Yes, sir. We don't hesitate, sir. We try to preserve. If not, we cut we ablate the structure, sir. Yes.
You ablate, because one of the common things that comes is the communication of the inferior ophthalmic vein with the pterygoid.
Yes, sir. Yes, sir.
So you dissect only with the bipolar diathermy.
Yes, sir.
Otherwise, once you cut it, it disappears down, which will not be in our field of vision.
Yes, sir.
You have this things. Otherwise, you routinely prefer titanium mesh, isn't it?
Yes, sir, because of the availability and ease of access, sir. But at times, patient, they may not afford a titanium plate. In that case, we go for a conical cartilage, sir. But if the defect is large, then we convince the patient to go for a titanium mesh. We have not used a bone graft, or we have not used a polyethylene, porous polyethylene sheet, sir. We have no experience with that.
I have just one this thing.
Yes, sir.
I personally prefer conical cartilage if the defect is 2 centimeter by 2 centimeter.
Yes, sir.
And because I think you can see this is the 2 centimeter piece.
Yes, sir.
So small.
Yes, sir. Yes, sir.
But,
I can understand, sir.
But when I think you are able to see.
Yes,
when
sir.
you put it into the orbit, I think one can appreciate the orbit.
Yes, sir. Sir, I can see, sir.
Yes, sir.
Yeah. And so all of you can see that orbit, but this is centimeter by 2 centimeter. In fact, it extends up to the infraorbital fissure, and it covers the whole of the floor of the orbit. When you go medially, it's almost ethmoid from here. This 2 centimeter by 2 centimeter. Outside,
Sir, can you just lift a little more, sir, specimen. Lift it a little more.
Yeah. How is it now?
It has to face downward. It has to look downward.
How?
Yes, sir. Yes, sir.
Huh?
Yes, sir.
Yeah. So this is a 2 centimeter by 2 centimeter defect on the floor of the orbit. Though outside it looks small, inside it covers most of the floor area. This is often I have noticed that, because I go with the idea my conical cartilage may not be enough, and most cases the defect is less than this, because you can see I am putting it inside. I hope you are seeing it.
Yes, sir. Yes, sir. I'm seeing it, sir.
Yeah. So this is exactly a 2 centimeter by defect. Of course, we have to take a little bit of larger conical cartilage graft. one thing I personally feel is something we can never bother about the infection. But of course, larger than that, you have to use the prosthetic plate. And when you use these things, implants, the most preferred implant is a titanium mesh. There's no doubt about it. Because elastic or porous, everything else, the complication is far more. And only thing is, there is, though any implant, so because it is in close proximity with the maxillary sinus, and the sinus never heals because there is always a communication. But incidence of infection is surprisingly very less in
Very
titanium.
less. We have not come across it.
Yeah.
Sir, actually, to be frank, we started with the conical cartilage, sir, when we started orbital surgeries, because we are in our hospital is in an area where the people are belongs to lower socioeconomic status. But contrary to our belief, when we say that we have to take a tissue from the ear for the reconstruction, we faced a very strong objection from the patients. They say that we even then when we opted for a titanium mesh plate, to our surprise, they said they are willing to pay rather than going for another procedure in the ear. So so that gave a confidence to us, and we started strongly suggesting titanium mesh plate. Very rarely, right now, we use conical cartilage there. But our thing is, we don't deny conical cartilage, but our experience made us just go with the titanium mesh.
Yeah, again, one more thing is, as you have very rightly said, there are two components, the inophthalmos and hypophthalmos. So whatever we correct, floor, reconstruct the floor, if we correct the hypophthalmos, if you want to correct the inophthalmos, you have to go posteriorly. That is, when you go inferiorly and posteriorly, there is a gradual tilt of the floor towards the posterior. Unless our graft or our implant goes beyond that area, the true inophthalmos will be very difficult to correct.
Yes, sir.
So, yeah, that is one thing. I think you have specifically told these 2 points, hypophthalmos. And is titanium mesh, is that posterior part is little bent or it is straight?
Sir, when we go for that base plate type, we find it little bit hard to contour, sir. It is so whenever we get a chance, we go for that contoured plate, sir, so that it gives the proper lift to the globe.
Yeah, this posterior part is preferably a little bent.
Yes, sir.
And in that case, only a hypophthalmos can get corrected.
Yes, sir. Yes.
Again, that infection, it's not as bad as feared in
Yes,
the
sir.
titanium mesh, and so many papers have come.
Yes,
but
sir.
unfortunately,
Yes,
I went through many papers. None of them, because everybody preferred their surgery. People have used bone graft, people have used, same persons have not compared cartilage and bone or cartilage and mesh or like that. So that is a thing. But certainly what the most important thing is your dissection. Your dissection and your willingness to go posteriorly beyond infraorbital fissure.
Yes, sir.
Because after infraorbital fissure, only the posterior wall bends.
Yes, sir.
The floor goes little up.
Up, yes, sir.
Yeah, only at that place the inophthalmos will get corrected. Thank you. Now I invite questions from.
Sir, there are a few questions in the chat box, sir. You're able to see them, sir?
Where? 1 second.
Or shall I just read out the questions?
Yeah, fine.
Dr. Alamelu has asked, in both videos, what fractures you dealt with and how did you manage?
Madam, the subtarsal was a rim fracture, madam. It is a rim fracture. It is not a full fracture. Just I have posted the video to show the approach, right? And the other thing, we went for the floor fracture. The transconjunctival approach video is the floor fracture, madam. Floor fracture.
Yeah. There is a question from Dr. Balasundaram. In case of orbital rim displaced fractures with floor of the orbit, do you use a separate plate for the rim, 4-hole with gap, and then a titanium mesh which is also fixed to the rim?
Definitely. We fix the rim before dealing with the orbital floor. We fix with the plate, then we deal with the floor. We go for a titanium mesh.
Dr. Insiat, sir, you have any comments on that?
Yeah, naturally, most of the, even recently, 2 days back, yesterday or day before yesterday, we had one orbital fracture. Orbit was in 5 segments. So and it's about a 1 month or 40 days old injury, referred from Coimbatore and all that. But once we reconstruct the rim from various this thing, we could see the floor. The defect of the floor hardly comes less than 2 centimeters. Because when we use multiple plates and there is going to be multiple pathways leading into the sinus, the chance of infection is more, the more hardware we are putting it. So if the autogenous cartilage, a conchal cartilage, is can bridge that defect, I prefer that only. No doubt about it. There's a chance of infection. There's nothing like cartilage graft. And again, there is a fundamental difference between a cartilage graft and a bone graft. You know, the bone graft take is very, very precise. You know, the bone has to, your graft has to be in contact with the bone. Cartilage, that is not the thing. Even if you put in the partly in the soft tissue or partly in the this thing, it takes very well. Again, there are instances after mesh infection, and because I know my basically I have my thing is in ENT, I am always aware of the complications of acute sinusitis and complication of CSOM, and you see an orbital cellulitis and orbital abscess happening, nothing else we can do except to remove those implants. So the more and more hardware you have to put, the more and more you have to be careful. Naturally, that will make you a little more nervous on a long term. Because once you put an implant, the infection, it's not 6 months or 1 year, it's lifelong. They may get a sinusitis after a few years. And if they have a complication, orbital complication, it's going to be a problem. But still, surprisingly, the incidence of infection with titanium mesh in all the papers, I don't know whether those papers are biased or not. All those papers are written by people who do only titanium mesh implant. They have not compared with the other kind of implants. That's it.
Yes, sir. There is a question from P. Umar Farooq Baba. In subtarsal incision, sometimes long-term edema becomes a problem. Any take on this edema?
That depends primarily, the post-op edema depends primarily on the pre-op status of the lower eyelid also. If we see preoperatively, if we see a patient with a consistent edema, then what we follow is we allow the edema to settle. We put the patient on antibiotics, anti-edema drugs. We wait for 72 hours, or else we even advise the patient to come back after 5 days. Then we take up the surgery. And post-op edema thing is, my take on the post-op edema is mainly it depends on the dissection. If the dissection is very precise and it is, if we follow the anatomy, I think we can avoid the post-op edema. If in case you develop post-op edema, if you think that the patient will develop a post-op edema, like what we suggest is we go for frost sutures, and that is the thing mainly. And we commonly use, we routinely use steroids, dexamethasone, for 72 hours to combat edema.
Yeah,
he suggested proper dissection. In fact, I like to emphasize proper repair when you come back. You know, because I never use a high profile plate in the infraorbital. That plate should not impair with your orbicularis muscle. Put a very low profile plate, and if possible, it may not be possible in badly comminuted fracture, close the periosteum or period thing over that plate, and then repair the orbicularis muscle, and then repair the skin. And then post-operatively ask the patient for vigorous massage. There should not be an adherence developing between the orbicularis muscle and your plate. If that is free, edema will never develop. And I have not encountered the edema problem. If it is persistent, sometimes it is adherent, you keep massaging. Even after 2-3 days, advise the patient to have a massage. After a week, vigorous massage that not only prevents the ectropion, it prevents the edema as well.
And sir said, one is the proper repair. After putting the plate in proper position, proper closure of the wound. We have to do a meticulous closure of the periorbita, a meticulous closure of the orbicularis, and the care should be taken in the closure. Then we can avoid edema.
Yeah, I think there are a few more questions. We have time only for one more question from Dr. Shashank. how do you approach an orbital floor fracture with medial orbital wall involvement?
See, same we subtarsal, we go for a medial extension. Say like it is just a isolated medial wall, we can go for a lateral nasal incision. Sometimes if it is associated with the floor, then we go for a medial extension. And if we are tackling the floor through a transconjunctival, then as I said, we can go for a medial curruncular incision extension. We can approach the medial wall.
Again, the medial orbital wall, it depends upon the medial canthal ligament. Either you are going to tackle with it and there is disinsertion of the medial canthal ligament, you are planning for canthopexy, it depends on that. If the canthal ligament is fine, only infracanthal area you are going to see or augment, you can have the same approach. There's hardly any need, same subtarsal, whatever tarsal position will do. But if you are combining with a medial canthal avulsion is there, then you have to do a canthopexy. Then it becomes no longer it is an isolated floor fracture. Because the canthal thing has to be approached and canthopexy has to be done. That determines to what extent you have to dissect medial orbital wall. And again, remember, optic nerve is in relation with the medial orbital wall.
Yes.
Rightly mentioned that thing we used to tell about the rule of 6 something, 12, 24, 36, like that. It come anterior artery, anterior ethmoidal, posterior ethmoidal artery is nothing. You can just coagulate with the thing. Beyond that, you have to be extra careful.
Yes, sir. Thank you, sir. There are other questions regarding naso-orbito-ethmoidal fractures and blow-in fractures. I think it's beyond the scope and we are running out of time. Thank you so much, Dr. Alagaraja, for a very nice presentation. And thank you very much, Professor NCH, sir, for your time and sharing your experience.
Thank you, sir.
Would you like to sum up before we close, sir?
Yeah, just few this thing. I encourage people to take up this orbit fractures. Every class you take it. Orbit, one need not be scared of it. Unless this is where you can show that you are different from surgeons of other related specialties. Because if we are afraid, we can be damn sure that they are more afraid. Because that is what my experience shows. When the orbit is involved, the case is always referred. Otherwise, they make an attempt. And start with the floor. Floor is the very safest place. As I told you, medial orbital wall is far more dangerous. There will be bleeding at 2-3 places. And then, of course, the optic nerve comes. And floor is a very safe place. You can very easily go up to the inferior orbital fissure. Only significant things come from the inferior orbital fissure. Even then, it's only the maxillary branch of this nerve. And then some vessels. You can even go beyond that when you are approaching the floor. And take it up. As far as implant is concerned, I feel you start doing with autograft because it's safer. Initially, you should not get infection. Once you gain more, and especially for larger defects, go for the mesh. And remember, you want to correct the inophthalmos, which is the most difficult part to correct. And you have to go posteriorly. That is, in the floor should go where it turns gently curves upwards. Unless you go that part, that is, unless you go posterior to the globe, you can't correct the inophthalmos. Only you will keep correcting hypothalamus. Second, regarding the impairment of extraocular movement, originally the blowout fracture is described. It is called the trapdoor fracture. Trapdoor has 2 elements. One, the door opens, then the door closes. If that happens in a blowout fracture, so when you see, there may not be a fracture, but there will be significant entrapment. I have encountered only 2 such cases. In fact, not only upward, that totally movement of eyeball is restricted in all the directions. This I encountered in a case where an ENT surgeon has done a FES. Accidentally, he entered the floor of the orbit. Small thing. And that like a trapdoor, it got closed and the muscle got stick. There will be restricted movement in all directions of the eyeball. And repeated CT showed only there is an adherence. No definitive fracture also was there. So this trapdoor component is very much important to cause restriction of the extraocular movement, to cause entrapment of the extraocular muscles or extraocular tissues. So most of the time when we see a large fracture, the extraocular movement will be normal only. That's what we surprisingly see in most cases. Thank you.
Okay, sir. Thank you again, Dr. Alagaraja and Professor NC Thank you very much. We'll go over to the next session. I'll just give the introduction. The next topic is microvascular flap take back, evaluation and outcomes. And the speaker is going to be Dr. Gele Ete. I hope I've got his name right. He's done his MCH in plastic surgery from Christian Medical College, Vellore, 2012 to 2015. He's done his, he's an assistant professor at the Department of Plastic Surgery, Christian Medical College, Vellore since September 2015 to the present. His fields of interest are reconstructive microsurgery, brachial plexus surgery, burn surgery, and reconstructive plastic surgery. And the moderator for this session would be Professor R. Krishnamurthy, who is a senior consultant plastic surgeon at the SIMS Hospitals, Vadapalani, Chennai. So I'll hand over the session to Professor R. Krishnamurthy. Sir, over to you, sir.
Should we start?
Thank you, Professor GK. Thanks for the opportunity. So straight away, we'll go for the talk. Professor Gele, please.
Okay. Good evening, Professor Krishnamurthy. Good evening, Karthikeyan sir. I'll start with my presentation on microvascular take back. Files.
Desktop presentation of
Good evening to everybody. Now, microvascular flap take back. This is in our experience in the last 5 years, which we have done first 100 cases. So the definition of a flap take back is an emergent return to operating room because of the suspected flap vascular compromise. Now, flap compromise is emotionally traumatic and very traumatic for the patient and also for the surgeon. And every possibility to salvage it should be done. The post-op protocol for anticoagulant, we start with the heparin 5,000 units loading dose when we elevate the flap, and then 8 hours later we follow with the heparin infusion of about 100 units per hour for next 5 days. For the flap monitoring, we use apart from the clinical examination, we use a Doppler, which is handheld Doppler 8 megahertz, then capillary glucose level of the flap, which we found it's a very helpful tool in our setup. Now, capillary glucose level, when it's a simple method where we just use the glucometer and scratch the distal part of the flap and assess and read the findings. It's a quantitative. It gives a quantitative analysis of the flap, whether the flap is working or it's compromised. Now, in the right hand side, you can see the picture where the glucose level is showing of the 53. So it's suggestive of a compromised flap. This is the paper which we have published in the European Journal of Plastic Surgery regarding the capillary glucose level in flaps. So when in this we have kept a cutoff of 61, but with experience we have realized we have like keeping a low threshold, we have able to salvage more flaps. So now the cutoff which we keep is the 100 milligram per deciliter of glucose of the flap. And this glucose usually corresponds to the patient's systemic level. Now, what are the causes of that compromise which we have seen in that? Most commonly, it was that vascular causes, which were the most common, but non-vascular causes like the traction, kinking, and compression also we have seen, and the infection, which has been a very difficult to salvage the flaps in such cases when the infection sets in because of the late presentation. While the other causes, like vascular causes, most commonly was the venous cause, which we have dealt with, and we could salvage few of the venous flaps. While the arterial flaps, we could also salvage the arterial flaps. Well, indeterminate causes, in one case, we had a free fibula fail, and we couldn't actually assess the cause of that failure of the flap. We had done a new procedure, something called osteointegrated implants in this first sitting for dental implants in that case. So probably while handling the fibula, probably vascular damage might have happened in that. So we also try to assess whether any type of flap has any contribution to the compromisation of the flap and the salvageability of the flap. So all these flaps, if you see the list, most commonly which we have done is the fasciocutaneous flaps, and of the fasciocutaneous, anterolateral thigh has been the most commonest one. The nominator of the number shows the number of cases which we have taken back to surgery for revascularization, and denominator shows the number of cases which we have done in them. So most commonly which we have done is the anterolateral thigh in the last in the first 100 cases, of which 9 flaps we had to take back, and we could salvage 6 of them. While in the latissimus dorsi, which we have been commonly using in initial cases, had a 5 take back, and we could salvage one of the flap, and other was a partial necrosis. While when you use the new flaps, like when you have early uses of these flaps, like lateral arm flap and supragluteal artery perforator flap, the understanding of the flap is, knowledge of the flap is a bit little. So most of the time you tend to have a complication with such flaps. So we had one gluteal artery, supragluteal artery perforator flap, and lateral arm flap, complete loss of the flap. While the medial sural artery we have been commonly using for the lower limb, and we couldn't salvage one flap which was taken for take back. While DIP flap which we have taken for the breast reconstruction, one we took back and could salvage it. And the radial forearm we used for a head and neck, 4 flaps we did, and one we took back and could salvage it fully. So the non-vascular causes, usually they present within 12 hours. Like since the condition, when the flap insetting is done, the physical factors comes into play. So probably that's why they present early in the post-operative period. While the infection, they present late in the post-operative period. Usually we have seen at 7 days, and they have presented with flap congestion. And one of the causes, one of the patients has come with a blowout of the anastomotic site on the 11th day. Now this slide shows a congested ALT flap. This flap on post-operative 8th hour, we saw the congestion of the flap. And when we just opened the anastomotic site, we saw the thrombus in the vein. This flap is done for a case where the patient had a contact electrical burns through the scalp, and there was osteomyelitis of the parietal bones. And we took the help of the neurosurgeon to remove that osteomyelitic bone. Now in this flap, when we put the ALT flap anastomotic to superficial temporal artery, we found that the pedicle got sandwiched between the flap and the bony edge, and this had caused the kinking of the flap and resulted in flap compromise. We could salvage the flap by slightly retracting the flap, and then kept a lot of gel form in the bony step deformity of that cranial edge, thereby relieving the pressure on that vascular pedicle. So we felt like that the flap design probably, which was centric, could have been eccentric, so by which that pedicle could not have come into the bony edge. That's what we felt in there. Similarly, there was another case which we did for the scalp, and again the ALT, anastomos to superficial temporal artery. And we tick all the boxes right in this case, except for the post-operative period when we asked the patient to lie down in one position to avoid the compression on the anastomotic side. The patient, when he lied on one position, the flap gravitated slightly. The gravitation of the movement of the flap caused traction on the pedicle. So we could just take back the patient to the OT and readjust the flap, and perfusion was restored. Now this another case where again we can see the flap is edematous and congested. This is a radial artery forearm flap, which we did for a patient with loss of nose because of the, probably it was vascular malformation of the nose following sclerotherapy. We are not sure what sort of sclerosing was given. The patient had a full necrosis of the nose and the forehead. So in this case, we planned a pre-laminated radial forearm flap. We pre-laminated with costal condyle cartilage, and for the inner lining, we put a skin graft in there. Now, if you see in this picture, there is a vessel in the base of the columella, so the neo columella which is going to be constructed. You can see there's a vascular pedicle. Now, when we took this flap for inserting in the second stage, this bending of the columella caused acute angulation, which had compressed the pedicle, and now this led to the congestion of that. So luckily, we could just find out the cause, relieve the columella, and reinserting was done after a week after debulking the cartilage in the base of the columella, and we could salvage the flap for this. Now, arterial causes of the 6 cases which we took back to the OT, four failed. And while one case we could revise the anastomosis and salvage the flap, and one had undergone partial necrosis. In this case, we had a little bit of difficulty in the cases because it was badly comminuted fractures where the vascularity of the limb was in question. So we had to do end-to-side anastomosis in 3 of the cases, and 3 of them failed. So this is a case where the flap failed, and we took for assessing what was the cause for, and if we could salvage that, but we couldn't do that. This is the defect in which we covered the flap. You can see that we have done the end-to-side anastomosis, and this is slightly, you can see that artery over here, which is end-to-side anastomosis to the anterior tibial artery, and actually it was a tenting of the artery. And when we explored that anastomosis, we found a thrombus in there. So the risk factors in this case, which we felt like was delayed in covering the flap, which was on 6 days after trauma, there was end-to-side artery anastomosis, probably that also may be a cause, and a lot of infection it was there, and the recipient vessel in the zone of trauma. And when we explored the vessel, there was an arterial thrombus in there. This is another case of arterial thrombus which presented very late. It was on the 11th day when the patient was almost like planned for a discharge. We found this flap discolored. Now this flap was done in the case of both bone fracture with malleolus exposed and ankle joint exposed. So the patient had compartment syndrome, and both bone fracture was reduced. After reduction, we found the anterior tibial was slightly damaged, and we had to explore the vessel slightly proximal to get next good vessel access. And we had to use a vein graft for the arterial anastomosis. So in this case, there was a compartment syndrome injury to the anterior tibial artery, and we use a vein graft. And probably when this patient was stopped on anticoagulant on the 5th day, probably the thrombus might have happened. And this is what we saw when we took the patient back. The collapsed artery with the pale artery, probably a thrombus which has caused that loss. So now the arterial thrombus, we have used Fogarty catheter in 2 of the cases, especially for the recipient vessel, not in the flap vessels, in the recipient vessel. And we could successfully restore the blood flow in 1 case. We don't have experience with the use of thrombolytic agents. Probably that's the reason we couldn't salvage many of the arterial thrombus flaps. Now we see the venous drainage, venous inadequacy in a flap, compromised flap. We have found the flap veins. When you take large flap, they have a 2 perforator, probably 2. We tend to take 2 perforators for large fasciocutaneous flaps. And this flaps will have a minimal 2 perforators draining. And when the veins, they confluence to form single vein, we have the tendency to do just 1 anastomosis with a single vein. Or you can have a flap vein where there's a different system, like in this case, in which we have a perforator coming from this perforasomes and this perforosome, and they confluence to form 1 single vessel. So our tendency usually is to do 1 anastomosis instead of doing it 2. Similarly, you can have 2 systems where you have flap being supplied by two perforators. This is a case of ALT which we got two perforators in a different system. It's not in a single one. So in such case, what we have seen is that if you take an example of this flap for this cover of the ankle, we have seen the flap was not doing good. The capillary glucose level of the flap also was lower than 100, and we found that there was a picture where the vein confluencing into one, and we anastomosed with one single anterior artery. So just see the picture. If you see that both the veins are engorged. The part which is proximal to the coupler and the part which is distal to coupler, both are engorged, fully engorged, and there's a discolor and there's a dark color of the vein in the distal part. So such pictures pretty much gives the idea that there's a insufficient venous drainage, probably because of the two veins confluencing and joining the one vein, which is not enough to drain the flap. So in such cases, better to do another anastomosis of the vein. So and then we could do that and we salvage the flap. This is another case where again the venous congestion was seen in. This is the immediate post-op, and this we saw 6 hours later in the congestion of the flap. It's as we do glucose levels. In these cases, we are able to quantitatively say that the flap is not doing good. And we took the flap for re-exploration and found there was a thrombus in the vein. And this is a venous thrombectomy which we did for. And again, similarly, the vein has confluence into one, and our usual thing is to take easy way of anastomosing only one vein. So that was the fault in that flap. We could again re-anastomose another vein, but we didn't find what you call another vein in the posterior. So we had to anastomose with a saphenous vein, and it worked, and the flap could be salvaged. So the flap average size of the ALT flap which we have seen, which can go into congestion, was like 22 into 14 centimeters. That means a larger flap, you need additional venous drainage system. So this is another case where you see a free groin, which we have done from post-bun contracture hand. You can see the congestion of the flap. So we took we had taken the flap based on the superficial circumflex iliac artery, and we had anastomosed to a radial artery. Now again, you can see the color of the vein proximal to the coupler. Again, there's dark in color, so probably there's a venous inadequacy was there in that flap. And when we saw you can see this groin flap with a CIS system, and this is branch from the saphenous system. So two veins were draining this flap, and we had anastomosed with the CIS system of the vein. So when we re-explored, we found a dilated engorge the veins of the saphenous system. So that indicates that there was a venous drainage inadequacy, and we did another anastomosis with the dorsal vein in the hand, and we could salvage the flap. This is the post-op picture of the flap. So another case where again the two systems of the vein were different. Like this is a large ALT flap we took for this defect of the leg of the foot, where the bone spacer was put and planned for a secondary reconstruction on a later date. So we had to put an ALT flap in this case. Now the problem with this ALT was that this perforator which we found was coming from the rectus femoris, and it was going down. We had to trace it to the lateral circumflex femoral artery. It was a tedious job. And since this perforator was not good enough, we found another perforator. Again, this was going beyond the femur. So still we kept the two perforators. And what we did was we had anastomosed the proximal vein with the proximal pedicles with the posterior artery, and two veins were anastomosed. But post-operative, we saw the congestion of the flap, and we had to bring the flap back. And when we did the supercharging of the vein to the vena comitans or dorsalis pedis, still the flap didn't improve. So probably there was, we could see that the edges of the flap was not bleeding well. So we had to do some arterial turbocharging to the proximal pedicle. And then the flap improved, and we could salvage the flap. DIB flap, which we frequently encounter for breast reconstruction, can give a problem of venous congestion because of the internal memory vein can be sometimes small in size. Usually we select the third intercostal space to get a good adequate size of the vein, but sometimes we have faced a situation where the vein was too small to drain the flap. But in this case, we could do something different in this case. We could salvage the flap. This is what we did in this. We have anastomosed this DIP flap with the internal memory artery and a vein. And since the flap was not doing good with the venous drainage, we had to do another anastomose to the retrograde vein. And we could salvage the flap. Now, this is an article which says that internal memory artery vein can be used for the anastomosis of the DIP flaps, but it has to be as a salvage procedure, not a primary vein anastomosis. So when to do a venous augmentation, we keep that simple picture of this anastomosis where if the vein is engorged on both the sides of the anastomosis, like even the recipient and the donor vein, if are both engorged, and see for the color. If the color is dark enough, it surely needs a venous augmentation, and you can do supercharging or you can do additional vein anastomosis. What picture we should get is the usual picture which we get is this picture where there's a bluish tinge of the vein. It should not be engorged, it should be free flowing. That's why when you get this picture, you can say your flap will do good. Sometimes the flap which we do can present a picture and you have a dilemma whether to take the patient for re-exploration. In such cases, we have found our monitoring tool of blood glucose level as a very helpful tool because it gives a quantitative value of the flap. So in this case, we were also worried whether to take for the flap for the take back for re-exploration. But the blood glucose level in this other part of the flap showed a good perfusion. So we didn't do and we could salvage the flap. So it helped us in undergoing some unwarranted re-exploration in the flap. So when we see the flaps which we have used, we found that a facial quickness flap which has a skin can give a readily detected, like it can be readily detected, while a muscle, probably the overlying graft may mask the findings of that. While facial quickness flap is a thin, metabolically less demanding, can sustain ischemia for a long period, while the muscle flap as metabolic demand is high, so can't sustain a prolonged ischemia. Facial quickness have a high take-back rate, while muscle flap has advantage of low take-back rate. A facial quickness can get a good take-back salvageability, while muscle flap has low salvageability. But we have to keep in mind that a single flap type of flap is unlikely to suitable for all the defects. And understanding an individual flap is equally important to see whether the perfusion of the flap is adequate or not. It takes, when you do cases and we do a particular type of flap, the familiarity brings confidence. So you can, like the confidence gives a better results in there. So now the timing of flap re-exploration is a significant predictor for a re-exploration success. We find a glucose monitoring, level monitoring a very good tool. Venous failure was easily detected and salvaged, while the infection presents late and salvageability is low. Arterial failure with salvageability is low, probably our inexperience with the use of thrombolytic agents. Take-back rate and salvageability rate is related to individual competence, and the competency improves when you know the reasons to your flap compromise or the fail. So it's always better to take the flap back and re-explore what is the cause for the fail. Thank you.
Can you just stop share? You have to stop share.
Oh, yes.
Dr. Gele?
Yes, sir.
Yeah. Thank you. You can come on. Your video is off.
Oh, sorry, sir.
Yes, sir. Hand over to
Yeah.
Dr. Krishnamurthy.
Yeah. Very nice presentation, Dr. Gile. First, let us straight away go into the question and answer. Then I will talk. The first question is, any experience on vasculitis secondary to infection causing flap failure, infected ulcer resurface procedure after initial debridement and wound sepsis management? How do you approach? from
It's,
Ajus Kasidhar.
We have experienced such cases where we had a flap failure secondary to infection and couldn't salvage the flap. When the flap presents, flap compromise presents very late, it's very difficult to salvage that. In cases, probably in such cases, we have debrided the area, we have taken off the flap and did the debridement part. And when the wound settles down, then we come with the new flap.
Yeah. Because infection is one of the deadliest enemies of a plastic surgeon. So also for the microsurgeon, you have to be doubly careful. Already you are doing one of the most difficult procedure, microsurgical procedure. There is going to be infection that will definitely compromise your flap success. But have you made any success in doing a free flap and re-exploring and salvaging?
No, in infection we have not done so. In infection we had all failed.
But you have mentioned, is the infection following?
Yeah, in 3 cases we had a flap failure, flap compromise because of the infection, and all the 3 failed.
Okay.
And the average day of presentation was about 7 days. It was not an early presentation also.
Okay. We'll come to the text. Then another question from Dr. Narayana Murthy. Lovely presentation. Is it the same surgeon who generally does the re-exploration, or is it different? Very nice. Do you think fresh mind legs will have more chances in salvaging? Do you have any 3-4 questions clubbed together? Let's go one by one. Is it the same surgeon who does the exploration? First question.
Yeah, it's the same surgeon who comes back to re-explore.
Okay.
It's the same team which we keep.
Very nice. Do you think fresh mind legs will have more chances in salvaging? Do we think junior fellows will have more chances in doing the exploration? Because senior take rest.
When we take the patient for surgery, there is the first person who is that postgraduate student who assesses the flap.
Okay.
And see the anastomosis side, what happens, and then we come into play.
Okay.
So they get an experience of what been done.
It is always the junior surgeons who help the senior surgeon in exploring. Probably I have learned that way. If you ask my colleague Dr. GK, he will also say that, because it always happens in the night, late night. So by the time we reach the institution, we would ask the postgraduate to do everything. Our only job is just to see the vein or artery. We will ask them to even cut and redo that. And that's the best way of teaching the younger generation. Do you have any preference with respect to superficial or deep vein as recipient veins in the lower limb reconstruction? Very important.
So the deep vein, usually we prefer a deep vein. We always, whenever there's a 2 vein along with the artery, the deeper part we always prefer.
Okay.
But again, after anastomosis, we see whether the vein, the flow color of the vein is good or not. If it's still dark in color and not to our satisfaction, we do the another anastomosis with the superficial vein.
Okay. But usually you prefer deeper vein?
Yeah.
In the leg?
Yes, sir.
Okay. Then the next question from Dr. Umar Farooq. It's a complex question. My query is, you also go for a patient blood glucose simultaneously. I probably comment, as it may depend on that, how you select cutoff. Any relation with plasma glucose like 10% less or so. That's what. How do you assess your flap glucose is normal or elevated or less? And how do you relate to viability?
It's correlates with the patient's systemic value. First you do the patient's, it's not every time we do that, but the first time when we take the patient out of the OT, we see the patient's glucose level, and then see again in the recovery the flap glucose, whether it correlates or not. Usually it's the same value it comes. So that's what it is.
Okay, very nice. Now let's come head-on discussion. What's the big importance of, there is already one standard terminology, re-exploration. What made you to give the topic take back flap?
So What I saw the literature, all of the re-exploration was said as a take back only. So that's what I.
No. I just want to know. When you say take back, does it give? Even though in the literature gives, but re-exploration definitely tells you the vascular anastomosis.
Yeah. Yes, sir.
So, there must be some more important, no?
Nothing specific, sir. No, I just found that the literature saying that re-exploration is a take back procedure, so I just gave it.
Okay. Nothing specific on that.
No.
Okay. Throughout your discussion, it was very nice. But 2-3 points I would like to emphasize. All these flaps you have mentioned, what is the nature of wounds or defect for which, whether it's due to trauma or burns or infection or cancer, is very important, no?
Yes, sir. Yes, sir.
Out of 100 flaps.
Half of our cases were of trauma cases.
Okay.
Some acute trauma.
Okay. Then the second one, the anatomical sites are missing. Because your most of the time, it is the flaps for the lower limb, they give problem.
Yes, sir.
Head and neck, probably 100% I can say now, as on today, can give success. Similarly for upper limb. If at all there's going to be any re-exploration or take back in your terminology flap, it's always the lower limb. But you have, all probably.
அது கூட தான் நான் டியூட்டி பண்ணிருக்கேன் ஆர்எஸ்ஆர்எம்ல ஒரே நாள்ல வந்து I did.
Yes, sir.
Hello.
Yes, sir. Yes, sir.
What happened to the screen?
Suddenly, I'm not sure.
Okay. The out of 100 flaps, you have 20. 20 is little larger, okay. But still you have salvaged almost 50%, 10 flaps.
Yes, sir.
Have you analyzed all these 10 flaps which you have lost with reference to the time lag between the anastomosis and the re-exploration? What is the shortest period and the longest period?
The longest period which they were the 11th day from the anastomosis to that flap re-exploration, and the shortest was 3 hours, where we just had a traction of the pedicle, so we could just readjust it.
But what happened to that 11th day re-exploration flap? Survived?
No, sir. Probably it was a arterial thrombus which had caused that flap. And
how come you missed the monitoring? Because they say after 7 days, it is very difficult to make the flap viable. Because I know, because I saw that. That's why I asked. Yes, 11th day, what prompted you to take the flap for re-exploration? You would have spent at least over 2 hours there on that.
No, till the morning rounds, the patient's flap was good only. Then when the evening, when we saw again, the flap had discolored. Okay. The patient was actually planned for a discharge on the 12th day. So we had stopped all the anticoagulants and were planning for discharge the next day.
Is it due to any thrombus or thromboembolic phenomena blocking?
In that case, we had anterior tibial artery damage because of the both bone fracture. And we had to go proximally to get a good access of the vessel and used a vein graft for that flap. And probably that has caused the insult.
And in your microsurgical work, all these flaps have taken the duration of the surgery?
Sir, the ALT flap which we frequently do is just takes 5 hours about.
Okay. Shortest?
No, the shortest will be 4 hours. The 2-team approach we have.
How many members of the team? Each team? 3 people, 4 people?
No, each team is 2 persons. Like elevation 2 persons and recipient vessel 2 persons.
Okay. Well, how do you go with your donor site? Because today the major talk is about donor site. The microsurgery started way back in 1970. Then slowly, step by step. And today, after 2000 perforator flaps, super microsurgery, today there are 2 flaps. When you raise a flap, you always think of another flap for your donor site. That's 2 or 3 days back, there was a seminar on microsurgery, super microsurgery. How do
Most
you?
of our donor site, we could close it with skin graft.
Okay.
And the most common flap which we have taken is the ALT. Our preference for the ALT is like the cases which we get is more of a lower limb trauma. And the same region we operate so that it becomes easier for us to elevate the flap from the same region. And post-op anesthesia, the epidural anesthesia works good for the lower limb. So this all advantages it has. And we don't have to turn the patient if at all we need to do an LD, which takes another steps, extra time for.
There is one question. We'll get back to the discussion again. Can these Skanda said very nice and practical presentation. Experience always is a collection of mistakes. Very nice, and it is important to understand them. That's fine. The question is the next question by Tanmay. Can the supercharging concept you said regarding situation of venous confluence forming one vein be explained again? Can you explain again your venous confluence concept?
And the supercharging concept is to augment the venous drainage of the flap. So it's usually is done on that recipient bed where you have put a flap and look for a flap which can look for a vessel which can be, or venous vein which can be anastomosed to the flap, thereby augmenting the venous drainage.
Drainage.
That's what is the supercharge.
Okay. I think it's clear for the audience. Now back to our discussion. Dr. Karthik, can we discuss for another 2 or 3 minutes?
Yes, sir.
Time, you need some more time.
Another 3 to 5 minutes.
Yeah. Back to Gile. This is one of the most important of advanced surgical techniques to be employed by the plastic surgeons. Unfortunately, right now I am seeing hardly 40 people are saying all microsurgeons are plastic surgeons, but not all plastics are microsurgeons. But what all you have been talking around, we are only concerned about this anastomosis of artery and vein. So one question regarding the artery and venous anastomosis. You are using regular stitches for artery and coupler for vein.
Yes, sir.
Or you use coupler for both?
No, we use coupler for vein only. So what instrument which we have is only for venous coupler. It's a venous coupler.
Why not for artery?
The artery is the thick wall and it's difficult to evert the edges and pin it on the coupler.
Easy to suture.
Yeah, easy to suture also.
Okay, what suture material do you use for artery and for vein?
Sir, my preferred is 90 ethylone.
Oh, fine. For vein?
Dr. Alagar
and vein we use 9 also.
Okay. Thank you. Thank you very much.
Sir, Dr. Alagar has raised his hand.
Yeah. Ask him.
Raja, would you like to ask a question or something? No. Okay.
What's the question?
Sorry, sir. Sorry.
Okay.
No, accidentally erased.
Yeah. And Dr. Purushothaman has made a comment. The assessing the plasma glucose level. He has commented that the ideal will be to assess the plasma glucose level at various quadrants before dividing the pedicle and compare with it post-operatively.
Good.
On that.
We have no knowledge or experience on that, but I am very pleasant surprised that as clinician, probably you belong to the modern generation. The clinical examination is the gold standard. Am I right?
Yes, sir.
And you have never mentioned the post-op monitoring. Is that the clinical examination histories have gone into the shell?
No, sir. The clinical examination is surely the gold standard. We have found this like the clinical examination varies with the person who monitors it. So in the night when the changeover comes, it becomes difficult for the person who has seen before to analyze the flap again. So this gives a like quantitative value to the flap, which like sort of gives a good value, which we can just jot it down in the paper saying that the glucose level at this hour was this much. And the next changeover comes and sees the same.
In none of your flaps, I have seen this streaking.
Scratch?
Scratch?
No, sir. We
Yes.
tend to do at the edge of the flap. We don't try to because it leaves a bad mark in the flap. The edge of
Always ever done rub and see. As
No.
Kishore said, you have to see the 4 quadrant. You have to see 2 or 3 places, no?
Yes. In the larger flap, like on most of the flaps, like I can say on the 2 of the flaps, we had done a quadrant. We have divided the large flap into 4 quadrants and assessed the glucose level, and then only we could then only we could like plan for re-exploration. Otherwise, on one side it was normal value.
What is the key decision making in taking back your flap? The 100 flaps.
Yes, sir.
What was the key in your decision making to take the black flap?
It was the set
clinical examination or blood glucose?
Sir, all combined, like it's sort of together. We have to take all the monitoring tools.
So how many microsurgeons are involved in these 100 flaps?
Sir, it's this flap which we have only one unit, one team which we have done that. So this is so in this we have 3 surgeons.
Okay, nice. Thank you. Thank you very much. All the very best. Thank you, Professor GK. Nice for the opportunity.
Thank you, sir. Thank you, Dr. Gele. It was a fantastic presentation, very lucid presentation about a very important topic in microvascular surgery. Thank you, Dr. Gele, and thank you, Dr. Krishnamurthy, sir, for your moderation and sharing your experience. Now, we come to the end of season 1. And at the end of this season, at the end of episode 14, I would like to thank all these people who have spoken, the moderators, and most importantly, no program can be a success without the participants and the participation by the active participant. I have a small synopsis of the presentation. I'll just share with you now. Just give me a moment.
Hey, I didn't came back.
Are you able to see the video, sir?
Yeah.
Thank you, everyone. It was nice having this journey of over 3 months, exactly 3 months. We started on July 15th, Plastic Surgery Day. And we have a lot of seniors in our participating in our session today. What we want is the advice from the seniors to the younger generation. Anybody would like to talk? Sir, Krishnamurthy sir, can you start? Just a word of advice to the youngsters.
Not advice, probably mingling with the younger generation. You know, today the lifestyle is totally different, high velocity life. So only one word, there is no substitute for hard work. And plastic surgery, is a heated discussion in the WhatsApp group. Even after 70 years, we don't know the name of our specialty. It's a pathetic situation. But as you youngsters, you build up all these 18 or 20 subspecialties. But whatever you do, you need to show your skill. One such thing is this microsurgery. Not only microsurgery, every surgical technique in plastic surgery needs your skill. So improve your knowledge, clinical acumen, use technology, just like GK is using. Probably is the first one using this, online. Use the technology to your advantage and improve your skill. Probably I'm comparing this with the last 3 months. We have a lot of seminars on the other side, Monkey's Clinic, the western side. They are in a different level. Let us see them. Let us also try to take our standards to higher level. Please, what we have missed, what we will be, what we have missed, we cannot gain. You should not miss. That's what my sincere. Please try to attend all the conferences. Try to listen to all these webinars. But focus on 1 or 2 subspecialties. But 3 or 4 are major. For example, hand and microsurgery, yes, everybody should. Then the trauma reconstruction of lower limb, facial-maxillary, the cleft lip and burns. So you concentrate basically on all these things, because in private practice, you need to have more of cases. And try to attend as many national conferences, at least 1 or 2 international conferences every alternate year. And go with some of the seniors for some years. Because one of the senior consultant presented in the last probably 2 weeks back, he was telling, he was comparing our surgery with the sports. In sports, everything is transparent. For example, you take the music competition, the talent search. So here we cannot have that, because we do not have clinical materials. But it is directly related to the clinical materials. You improve your skill, it is related to the outcome. Compare with that, compare with world national standards and world standards. And we are always here as seniors to help you. Please go ahead. All the very best.
Thank you, sir. Dr. Prabha Yadav, madam. Dr. Prabha Yadav, madam. Dr. Sridhar, sir.
I have just
Prabha
joined, so I don't know what's happening.
So we just want your advice to the younger generation, because this is mainly for the younger generation.
Yeah, younger generation have such a knowledge open to them to absorb. It's at the fingertip, which we didn't have at that time.
Correct.
So now you have, previously I would say there were few seniors who would not impart their knowledge, because then you are the future competitor. But that thing is not there now. If you don't teach people, go and learn it somewhere, whoever wants to learn. I think it is just your attitude, your hard work and your dedication. I think anything you do, and you should do whatever you want to do, is that this is my best thing that I am going to give it. Then only you set your own standards for yourself. You don't compare yourself with somebody else. So you need to that what can I do is today will be my best surgery of my life. Then you will give your best to that. So I think anything, whatever you do it sincerely, do it. There are many seniors who are there who are willing to help everybody, whoever asks for advice, and sincerely, open-mindedly it is given. So I think they should utilize all these opportunity, and they are smart, they are good, they are hardworking. So I think they will always excel in their fields.
Thank you so
Wish
much.
them all the best.
Thank you so much. Dr. Sridhar sir.
Yeah, thanks a lot, Karthi, for an excellent session. That's number one. I think I'll come straight to the point. I think majority of the talks were excellent. I must say they are all really, I think they have come up to the mark. I don't think they are all juniors or youngsters. They have done a good job in. I would like to tell few points about presentation as such, because that is what we are talking about now. Number one, I would like to tell some of them. Be brief on your introduction. Number one, come straight to the topic's point. There's no need for you to talk about the introduction in a broad way. You have to come back to the point. Number two, you have to stick to your time. These two requires rehearsal. So these two, I think you will have to do. Cut down on slides on coming to the point. Before that, whatever you are doing, you reduce the number of slides and then come straight on to the point. That's number one I would like to tell. Number two, make your slide background normal and clear rather than many gimmicks all around. So it is much better to make an impression that you must have a background which is clear, with a font which is in front of it, which is a contrast to that background. That must be very clear, not so many things which distracts your attention to those graphics rather than the point which you want to tell or convey. This is number two. Third, don't read from the slide. Whatever you have there, the person is there to see. Therefore, you have to make a brief comment on what is written there rather than reading the slide directly. Point number 1, 2, 3, 4, don't read it, but you concisely, you tell, but what are the bullets points are there, they can always see it. I think these are the few things which I would like to tell, saying that your presentation must be this way. And more, if you are doing videos, I think the videos must be rehearsed and they must be in the corresponding folder. Then only it will start working. We have found many times, sometimes the videos were not working. The reason for that is they are in a different folder and they are not in the same folder, and the computer is searching for from where it is come, because it knows only the path. So you must make sure that they are there and they are compatible. These are the few points which I would like to tell on the presentation part of it. Number one, come straight to the point. Don't beat around much on introduction. 2, make your slides simple color contrast. 3, the size of your fonts must be not more than 40 for the headline, not more than 24 or 28 for the body. Otherwise, it will be too gaudy. So the body must be around 28. Title must be between 36 and 40 is the maximum. Don't go beyond that. And not more than 3 colors. And not more than 6 lines in a slide. Anything above 6 lines is like a railway timetable. Nobody can read it. So you must remember these few points, which I thought may be worthwhile. Next time we can have something on presentation itself as a topic for our plastic surgery, because this requires a lot, because you've got a lot of figures, photographs. I think that itself is worth. Thank you. I think it's an excellent thing for the 3 months. I think kudos to you, Karthik, for organizing this in a grand way. And I must really appreciate the juniors. They have done a remarkably good work. They are keeping in touch with the technology. You must walk with the progress. Without walking with the progress, you are coming to a standstill, which I found it is really great. I think I would like to applaud them for that. Thank you.
Thank you, sir. Can I ask Dr. Chandran sir to give his comments and advice to the younger generation?
Hello, everyone. First of all, I would like to congratulate you, GK, for the excellent job you have done all these months. It has been a wonderful experience to sit over these wonderful lectures, and I enjoyed every moment of it. It was very entertaining, and on a personal note, I learned a lot. See, after a particular point in your career, you have a sort of a restricted practice and you tend to concentrate yourself in one particular aspect of plastic surgery. So you will certainly want some exposure to the other areas. Now, this platform gave me that, and I personally, I learned a lot. Regarding your statement on advice, I do not know whether the younger generation would like advice, because that itself puts them off. That's what I feel. Maybe the elders have some experience in their personal life, in their professional life, and try to take some decisions and want to impose those things on the youngsters. But certainly they should form their own experiences. Only few points I want to emphasize. In this entire 3 months, I found that there were a lot of microvascular subjects and aesthetic surgery subjects. Apart from that, I don't see cleft lip and palate, I don't see burns, I don't see hand, which was little disturbing to me. I have started feeling that possibly we are losing out on all these specialties. Even in aesthetic surgery also, there has been a lot of innovation from other branches. So we need to be very, very careful. And please understand, if you want to select a particular subspecialty, every subspecialty requires a proper training. Be it micro, be it aesthetic, be it cleft lip or whatever it is. You can't escape from being very, very competent in whatever you do, just like Dr. Prabha Yadav said. You need to improve your level first. For that to happen, you need to assess your own results. That's what I found extremely interesting. For example, now I'm trying to analyze my long-term results. Some of my cleft lip cases, bilateral cleft lip, unilateral cleft lip, I'm trying to review them after 25 years. 25 years ago, I have operated. So I'm trying to get their photographs. And then I find that that itself is highly educative to me. So that is what the youngsters need to do, review their own results. Then they will understand what are the mistakes they committed in one particular case. Like the micro presentation now today. Excellent. He reviewed his own results. That is what is required. That is what is required for you to improve on yourself. Please understand, even great surgeons have tried to improve on their own techniques. Even Millard did it. Millard designed a rotation flap, but thought there was some flaws in that, and he improved on his own design. So you need to improve on your own results. So that is one basic thing. Regarding the presentation, I'm certain the quality of presentations will keep on improving. As rightly pointed out by Sridhar, that those things need to be addressed to. For example, don't read the slide, only have 5 or 6 lines in a slide. Those things need absolutely important, and be precise in what you want to talk. Don't browbeat. You should be very crisp in your presentation. That because you will lose your audience in no time if you are dilly-dallying and keep on meandering. So you need to be very crisp. So otherwise, that is what I wanted to say. Review your own results, try to improve on this, and every branch in plastic surgery requires a lot of training. So please undergo that training before you attempt on your own. Thank you very much, GK.
Thank you so much, sir. Thank you. Dr. Purushottam, sir, would you like to comment?
Can you hear me?
Yes, sir.
Thank you, Karthikeyan. I think that was wonderful on your part to organize such a beautiful meeting and bringing out all the hidden talents or probably needed little push-up or a little helping hand. So that was wonderful of you. I think partly to answer Professor Chandran's apprehension that some of the topics were not covered, I think you will have season 2. If I'm not mistaken, there is season 2, I think. Probably
Next
he
year,
will
sir.
cover it. Karthi will cover all the missed out topics in season 2. And the
Yes,
only
sir.
thing is, you have been very liberal with the timings of the presentation. So when they go for national meetings and they have to be fine-tuned themselves, and what Dr. Sridhar said and Professor Chandran said, they will have to fine-tune themselves and to be very precise and try to convey exactly what they want to say. So that is what they have to work on it. I think It's an excellent forum for all of them. Congratulations, and congratulations to GK also. Thank you.
Thank you so much. Thank you, sir. So now we come to the end of the first season, and I would like to thank everyone here, as I said, and we shall meet again in a different format. Of course, season 2, as Dr. Purushothaman said, will come, but there's time for that. But in the meantime, we'll have another program, a different program, and with the same amount of encouragement from all the seniors, I'm sure we'll go a long way, and our fraternity will grow. Thank you very much, and good night, everyone.
Three cheers to Karthik. Three cheers.
Thank you, sir.
Thank you. Good night.